Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is 9th August 2025. This video is on an open access article published on the 1st August 2025 titled Cardiac Manifestations of Fabry Disease in Nature Partner Journals Cardiovascular Health. Fabry disease is an X-linked lysosomal storage disorder due to alpha-galactosidase A deficiency, where the accumulation of lyso-Gb3, that is globotriazoceramide. There are two phenotypes: the classic Fabry disease, less than 3% enzymatic activity, multi-system and early onset, and the variant or the late onset Fabry disease, residual activity, and is dominant, cardiac dominant. Pathophysiology: dysfunction of the lysosomes results in inflammation, oxidative stress, vascular smooth muscle proliferation. This in turn leads to cardiac fibrosis, microvascular ischemia, and cardiac arrhythmias. Deposition of Gb3, that is globotriazoceramide, and lyso-Gb3 deposition in myocytes, endothelium, and conduction system and heart valves. Epidemiology: historically rare, 1 in 40,000 males, but newborn screening shows higher prevalence, 1 in 1,642 to 1 in 3,859 in Asian and European cohorts. Fabry disease accounts for 0.5 to 6% of hypertrophic cardiomyopathy cases. Over 80% of Fabry disease patients have cardiac involvement. Cardiac complications: LVH, concentric more than asymmetric, diastolic dysfunction, often EF is greater than 50%, so it's HFpEF. Cardiac arrhythmias: atrial fibrillation, ventricular tachycardia, conduction blocks, microvascular angina, valvular regurgitation, mitral greater than aortic. Aortic root dilatation is common but rarely severe. Suspect in unexplained left ventricular hypertrophy or hypertrophic cardiomyopathy or HFpEF-like picture. In men, alpha-galactosidase activity plus genetic confirmation. In women, genetic testing is mandatory. Imaging: echo, LV strain. In cardiac MRI, late gadolinium enhancement, low T1 mapping. Red flags: cornea verticillata, angiokeratomas, neuropathic pain, and albuminuria. Management: enzyme replacement therapy like A-galactosidase alpha and beta, most effective before fibrosis. Chaperone therapy: migalastat for amenable GLA variants. Investigational gene therapy is going on and substrate reduction therapy. Supportive care: guideline-based heart failure, arrhythmia, and angina treatment. Caution with certain antiarrhythmics. DOACs for AFib regardless of Childs-Vass score. So what is Fabry cardiomyopathy? It's a deficiency of alpha-galactosidase A, accumulation of Gb3 and lyso-Gb3 in cardiac myocytes, endothelium, conduction tissue, resulting in fibrosis, cardiac hypertrophy, and microvascular ischemia. How do classic and variant Fabry disease differ in presentation? Classic Fabry disease presents in childhood with multisystem involvement. Variant of Fabry disease appears in adulthood with predominantly cardiac symptoms and less systemic disease. Which cardiac findings are most common? Concentric LVH, diastolic dysfunction, HFpEF, atrial fibrillation, ventricular arrhythmias, mitral regurgitation, and microvascular angina. How is Fabry disease differentiated from other causes of LVH? Low native T1 on cardiac MRI due to lipid accumulation, late gadolinium enhancement pattern, basal and infralateral, genetic testing, and extra cardiac red flags. What is the role of genetic testing in women? Essential. Enzyme levels may be normal due to X chromosome inactivation variability. What's the benefit of ERT? That's enzyme replacement therapy. It reduces LV mass, improves function, decreases adverse cardiac events, most effective before irreversible fibrosis develops. When is migalastat used? In patients above the age of 12 with the EGFR greater than 30 and an amenable GLA mutation. Why is early diagnosis critical? Therapies work best before fibrosis. Late initiation yields less cardiac benefit. Are there risks with standard cardiac drugs? Yes. Avoid amiodarone, use beta blockers cautiously, and avoid class 1C cardiac arrhythmic agents in structural disease. What investigational therapies are emerging? Gene therapy, lentiviral vectors, targeted alpha-Gal A delivery, and substrate reduction therapy. How common is aortic dilatation in Fabry disease? 30 to 56% of the men and about 21% of the women, usually mild. Why is Fabry disease sometimes mistaken for HFpEF? Heart failure with EF greater than 50% is common, but if Fabry disease pathophysiology, natural history, and treatment differ, what red flag should trigger Fabry disease suspicion in cardiology? Unexplained LVH, hypertrophy of papillary muscles, mitral and aortic valve thickening, conduction blocks, and extracardiac signs such as angiokeratomas and neuropathy. How accurate is newborn screening? It detects enzyme deficiency, but genetic confirmation is needed to determine pathogenicity. What is the annual cost of enzyme replacement therapy and its limitation? It's around $200,000 a year, limited tissue penetration, and doesn't reverse fibrosis. There are no celebrities with Fabry disease, but there are several advocates. Wes Burian, a former visual effects artist and surfacing supervisor in animated films, now retired and active as a Fabry disease advocate. Jack Johnson and family. Several generations of the family had Fabry disease. He is an executive director of the Fabry Support and Information Group and vice president of the Global and Americas for Fabry International Network. He leads advocacy, fundraising, and community engagement for Fabry disease. Craig Cordell is another recognized advocate for Fabry disease awareness, focusing on delayed diagnosis and patient education. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.